Afternoon, colleagues. I think we have a quorum on the line. So I have a very brief job to do, which is just to welcome you before handing over to our chairperson for the day. So I really want to extend my welcome to the Malawi and the Kenya and the Mozambique South-South Learning Network champions who've been invited to this session today. And I want to give a really special welcome to our hosts for this session today, who are Zambia. We're really excited to have you hosting this Link and Learn today on a total market approach to condom programming. We know that this is an area that the Zambia team has scored themselves highly on in the PSAT, and we recognize and applaud the progress being made in the country in terms of developing a total market approach strategy. It's really my privilege today to invite Dr. Bupe Musonda to take over this session. And so with that, over to you, Doctor, and thank you very much.
Thank you, Kerry. Good afternoon, everyone. Good afternoon, colleagues. As mentioned, I'm Bupe Musonda, coming from Zambia, the Ministry of Health. So a bit about myself is that I'm the HIV prevention advisor at the Ministry of Health. So we basically overlook, together with the National AIDS Council, support each other in looking at the condom and lubricant programming. So a brief about how we operate is the HIV prevention program in Zambia works according to the 5 pillars that are known, one of which is condom and lubricant programming. So this, we have the implementation aspect of the program and the coordination aspect of the program. So we have my colleague from the National AIDS Council, Ellen Mubanga, who will take us through what Zambia is doing in terms of total market approach for condoms. And this approach that we used was based on the review that we had, some background information where we actually saw that our condoms are not reaching the last mile. And one of the things that alluded to this of not reaching the last mile was on the marketing. Our commercial condoms being available and being accessible to all, including both in the urban and rural populations. So I think Madam Ellen will be able to take you through all of this, and please feel free to engage, and we're eager also to learn from you all and see how we can improve our program. So without further ado, Madam Ellen will take you through the first part of our presentation, which is the overview. Over to you, Ellen. Thank you.
Thank you, Dr. Musonda. And thank you, Kerry, and welcome to everyone who's joining us on this Learning Network platform, which we have been sharing a lot of information, learning from others as well. As Dr. Musonda said, and Kerry in our introduction, we have adopted the total market approach, and this total market approach is to help us ensure that we reach our last mile distribution, but also ensure that we have a well-coordinated condom programming program as a country. So I should hasten to mention that we are in the process. We have not concluded, but the process has commenced and has reached advanced stage in terms of developing the national guidelines and plans for the implementation of a well-coordinated condom programming using the total market approach. So I'm going to walk you through a presentation which will look at, in total, we'll look at the overview, but also we'll look at the practice presentation, the elements that we are looking at, the key contributions that we are applying to the TMA strategy, and also what are the innovations and adjustments. And of course, we'll conclude with the challenges and lessons that we have learned. And then we'll have an open discussion, and thereafter a summary of commitments and next steps. So to present this, I will be assisted by Mr. Maxwell Kasonde from Ministry of Health, as well as Mr. Daliso Mumba from National AIDS Council. Thank you. Next. Okay, so as an introduction, the health sector guiding principle in Zambia is that the provision of equity of access to cost-effective quality quality health care as close to the family as possible. So the health sector in Zambia strives to attain universal health coverage. However, the main challenge has been reaching all Zambians in need. So the main principle is to ensure that we have equity of access and ensure that we bring the services closer to the family as possible. Next. Okay, thank you. So in terms of the total market approach, when we narrow down to our context, we are looking at the three areas or three sectors or three arms that we are working in. And in Zambia, we have condoms that are provided by the private sector. We also have public sector, and we also have socially marketed condoms. So basically, we are operating from these three arms in terms of total market approach. The private sector, the public sector, and the socially marketed condoms or social marketing arm. Next. So the private sector, what is involved in the private sector in terms of condom programming? In the private sector mainly targets the middle and higher income brackets. And we find that these are looking at diverse groups, but they also have branded condoms. Mostly the private sector provides a variety of branded condoms. They are some are scented, different makes from different companies. So they have a mix in terms of the type of condoms that they provide. And most of the private sector condoms are commercial. We do have one or two that are free, but the private sector condoms are commercial. And these are found in usually drug shops and pharmacies. We now have also come to the public sector condoms. The target is all populations, and often these are distributed in public health facilities. They are usually unbranded condoms, and mostly they are also used for family planning. That is why through the public health facilities, the main focus or the main target is family planning. But we do also have partners who complement government health facilities with branded free condoms. And these free condoms are coming in through partners who also distribute condoms, but they are for free. We also now have the social marketing. For a long time, Zambia has done very well in the social marketing aspect. From the early times that we started to focus on prevention of HIV, STIs, and of course, unintended pregnancies, social marketing has played a very pivotal role. But we will see that at one point, this aspect was disturbed due to change of implementing partners, but it's a very strong arm that we have, and would like, through this total market approach, ensure that it is well strengthened, complementing the private and the public sector. So targets, this part targets mainly condoms to the middle income, and those condoms that are addressing the different flavors or the different brands, but it is subsidized at a subsidized price. So the implementing partners usually who are involved in social marketing also carry out mass condom demand creation activities. This is to ensure access, information, and information dissemination, as well as acceptability of the condom. So the main players in Zambia have been supporting this through especially the PEPFAR-funded projects, have supported the social marketing aspect of the condom programming in Zambia. Next. So why are we using the total market approach for Zambia? Why have we focused on this? This approach will help us improve the functioning of the health market. And how does it do this? It will by better targeting of free and subsidized products, creating demand for specific health products and services. And in this case, we are talking creating demand for specific condom products and its services. And of course, to ensure that we reduce supply chain inefficiencies and overlaps across the sectors and the programs. We are looking at this aspect of supply chain inefficiencies. At the moment, I should hasten to say that, yes, we have all the players in place, the private sector, the social marketing, as well as the public sector involved in condom programming. But what we have experienced is that we have not well coordinated these key partners. And as a result, we are not so much up to with data, up to standard with the data. How many condoms are we channeling through, especially the private sector? We are not recording that, and it's not part of the main supply chain in terms of accounting for the condoms. So that is why this is one of the reasons why we want to ensure that the total market approach in Zambia becomes effective and efficient and ensures that we reduce the supply chain inefficiencies. Also to ensure policies better enable private sector entry, participation, and growth in the health sector. So we are saying that using the condom programming and using the TMA approach for Zambia, we want to ensure that policies are favoring also the private sector to participate in the health sector, especially in commodities such as condoms. Then the other reason why we need the approach to help us improve the functioning of the health market is to have a well-coordinated market space. So we are saying coordinating market players well, the donors, the NGOs, the private sector who are for profit, but also the public sector and all those who are supporting condom programming in Zambia. Next. So according to what we have outlined in our condom strategy, we are targeting the following populations for Zambia, and that is why all three players are important in addressing these different types of population. We are targeting adolescent girls and young women, boys and young men, women and men, people living with HIV, truck drivers, public transport operators, seasonal and migrant workers, key populations, the orphaned and vulnerable children, and those living in the streets, and of course, people with living with disabilities. So this is the target population that we have outlined even in our national condom, comprehensive condom strategy. Okay. So in enhancing the why as well, the why are we doing this? Why are we focusing on this? We see that when we look at just percentage of teenage pregnancies as a country, because teenage pregnancies is a proxy that gives us an idea that we have a number of sexual activities happening that are not protected, and therefore an avenue for HIV transmission, an avenue for STI transmissions. So when we look at this map, unfortunately, although I'll endeavor to ensure that I give the numbers correctly, we have, okay, so the numbers that we are seeing are giving us an idea of our provincial standing. When we look at Eastern Province, we have 39.5, and we look at Northwestern, we have 41.2%. We look at Copper Belt, we have 21%. So generally, this gives us an overview of the type of scenario we have around teenage pregnancies. The numbers are very high, and therefore this shows us that our young people are getting pregnant, our adolescents and young girls are getting pregnant, and this means that they are not using condoms. Is a sign and a proxy indicator for us to know that condoms are not being used. When you look at the figures that we have, over 40% of young people who get pregnant in our different provinces across the country. We have 10 provinces around in Zambia. Thank you. Next. So in terms of HIV prevalence by province, according to our Zambia Demographic and Health Survey, this year, at the end of this year, we will have new updated prevalence figures because we have the Zambia, the fear that is taking place right now for Zambia. But according to what we have and our current statistics that we have, our ZDHS shows that across our 10 provinces, we have 15.40 as the highest in terms of prevalence, and this is on the Copper Belt province. And then we have Lusaka province, which is 15.1. And our lowest is Muchinga province, which is about 5.4%. So this is the distribution of prevalence according to our provinces as a country. In terms of the overview response, according to Spectrum estimation, we have a population of about 1.5 million people living with HIV, and the number of people who are on treatment, approximately about 1.2, and then our prevalence overall is 11.1%. And as a 2020 estimation, we have an estimated annual infection of 61,000. And viral load suppression among people who are living with HIV is 89%. Next. The next slide is showing us HIV prevalence in the subpopulation. And according to this one, it gives us a general, and then it gives us specifics in the subpopulation. So if we look at our the slides being reflected there, the general population, like I mentioned, is 11.1. We have inmates about 27.4, MSM 33%, IDUs 26, and sex workers 56.4, with adolescent girls 8.1 and adolescent boys 2.1. So this one gives us an idea where we have a higher prevalence in terms of a number of people with who are living with HIV in a particular population. So this is for our subpopulations. Next. Okay. So for Zambia, why are we focusing on adolescent girls and young women, especially in our programming? We know that we need to, because of what statistics are showing and what is happening on the ground. So when we look on the side there, we have 26% of adolescent girls report first sex as coerced, meaning that we need to also address issues of sexual gender-based violence. So we have 26%. Then we also have 69% of girls of our girls by the age of 18, they would have already had sex. And 29%, that is 20 to 24, report intimate partner violence. So all these are indications why we are focusing our programs on adolescent girls and young women and treating them as key populations, priority populations, in order for us to reduce new infections and reach epidemic control. Next. Next. Next, okay. So basically this one, according to our 2020 new infections, which just go back. So anyway, the slide before this one is showing us new infections, like I indicated, in the 61%. Thank you. Just to indicate that this was
Ellen, are you still there? We seem to have lost you. I'm not sure, Zambia colleagues, if you can hear her, or if anyone else is able to perhaps support if she's dropped.
No, we are unable to hear her. I mean, I'm in Zambia. I think there's something wrong with her network.
Yes, I equally cannot hear her. Daliso, are you on the call? Maybe you could continue for Madam Ellen. Mr. Daliso Mumba, are you available? Oh, Mr. Daliso Mumba is on the call but unable to unmute. Right. Kerry, how would you propose, as Mr. Mumba is trying to contact Madam Ellen, how would you propose we proceed?
Perhaps we can just give a minute to see if Ellen can rejoin. I think I should be able with him as well. Maybe we'll just quickly chat to him and see if we're able to.
Okay. Sorry, I think I lost connectivity. Are you able to hear me?
Yes, we are.
Yes.
Okay, so I was on this slide just to indicate in terms of new infections, trend from age 15 to plus, showing us in 2020 that we had 61,000 new infections. We can go to the next slide. Okay, so in terms of condom programming, where are we? According to our 2020 spectrum analysis, we have women in terms of condom use as at last sex, 35%. Our men, 54%. And in terms of estimated condom distribution need met, we are at 11%. Next. So that is the general population as at the last sex. Sorry, this is from the ZDHS. So for these female sex workers, where are we? So the sex workers and their clients. So we find that in terms of condom use, last paid, we have 79%, while for clients, 56%. So showing us in terms of when it comes to condom use, how are the sex workers using condoms and their clients. So we find that clients are lower than the sex workers. And this gives us an idea where in terms of messaging, how do we need to focus and change our messaging towards the clients of sex workers. Next. So when we come to adolescents, and this is 15 to 24 and their male partners, we find that adolescent girls and young women and male partners, for the young women, 34%, while for the young men, it drops further than 54%, it comes to 49%. So this is the scenario that we have in terms of condom use by our subpopulations. Next. Okay, so basically that was the overview in terms of where are we, what are we doing, I mean, in terms of the picture that we have in our HIV response, and as well as focusing or narrowing to condom use, giving a synopsis of where we are. So at this moment, I'll move on to the part 2, because part 1 was just the overview of where we are. So what are the the TMA elements in terms of, for Zambia? What are we focusing on in the TMA? We are focusing on strategic targeting. As you can see that we need to have strategic targeting, and we want to ensure that all the 3 arms are targeting strategically in terms of condom distribution, access to condoms. Then regulatory and policy environment, making sure that we have the correct approach in terms of what is on the ground in terms of regulatory and policy. Then we are also looking at procurement. Procurement not just for the public sector, but we are also looking at procurement for the private sector, and also the part of the socially marketed condoms. For the private sector, basically it's just to harmonize, to know how what is coming in and how they are distributing, how they are selling, and make sure that the public sector, the private sector procurement, and the private sector, public sector procurement are harmonized. That is why our TMA is also focusing on procurement, and also target markets, the different market spaces, the distribution. One of our greatest challenges has been last mile distribution. So in this TMA strategy that we are employing, we are saying distribution is very important. So it's one of the elements of our TMA. Of course, cost recovery, and cost recovery is not for public sector and the socially marketed condoms, but for the private sector. Of course, we are asking them to engage more, to engage fully. So how do they recover some of that cost? So in the TMA, we have that element of cost recovery for private sector. And of course, segmentation, which is very, very important, not just for the segmentation of populations, but also segmentations of the markets, the different levels of how we will operate. And of course, a robust linked M&E system, which is very important. Without this, we'll not be able to know or tell how we are progressing in condom programming. Therefore, we need a robust linked M&E system. Here in Zambia, we have our ZAMSA, which is the main hub, the main institution that procures all health commodities, and condoms for the public sector are procured through them. And they have a system of monitoring. But we also have now the reporting system. We have the reporting system through the Ministry of Health. We also have the reporting system through the National AIDS Council. And now we are saying, how do we harmonize the 3 arms to be able to capture data throughout and for all of them, and linking them to the main system and having one that can speak to our condom programming alone. So robust linked M&E system. So these are the elements that we have identified that are in our TMA approach. Okay. So what is helping, or what is contributing to what we are doing are the following, both from the government arm as well as from our partners. We have the National Condom Strategy. We have a quantification and supplies plan. We have, through the support of the UN system, as well as the Global Fund, we've been working and developing the Condom Strategic Initiative that is also contributing to ensuring that we have an effective condom programming program intervention in Zambia. Then we also have the National AIDS Strategic Framework, as well as the TMA landscape assessment. The TMA landscape assessment is something that we have used and also using to inform our programming in TMA, because this was done by one of our partners, but of course, with working with the Ministry of Health and working with National AIDS Council. Okay, so what are the innovations that we bring to the table, or that we hope to use? The innovations is that, number one, we are strengthening integration of programming with health services and other non-health services. What we mean is that for a long time, for us, condoms have been mainly channeled through the health facilities. And the little that goes into the public space from the non-health facilities hasn't been much. So what we are saying that right now we have embarked on ensuring that we strengthen integration of all health services to make sure condoms are in all health services, but at the same time also the non-health services. So for this, we are working out a program for community-based and intervention that will ensure that condoms are at all levels in all spaces, whether health or non-health. And in non-health activities, we're also thinking of the major, for us, we have all these major traditional ceremonies, we have all these sporting activities, we have all these marketplaces where we have businesses happening, agricultural spaces. So how do we integrate? So for us, it's an innovation to ensure that there is integration of programming with health services and other non-health services. Of course, the second point is that the innovation is to ensure that we have an integration of electronic logistics management information system, like I've explained, and harmonized one, which encompasses all the other dimensions where condoms are programmed and distributed and accessed from. The other innovation that we have is that as a country, we have developed what we have regional hubs. And these regional hubs are helping us collapse the distance of collecting condoms. In the past, everybody from all the 10 provinces would collect and apply for condoms or commodities directly from the central distribution point. But right now, we have hubs, and this has contributed significantly now to reducing the distance between the regional hubs and the districts, because now the districts, which is the last mile distribution, will be able to move a shorter distance to collect condoms. Although, of course, we may still have challenges, but in terms of a step moving towards the last mile has been made, and this is in the establishment of regional hubs, which are now housing condoms at that level. The fourth point in terms of innovation and adjustments that we are making is that mapping of potential and or existing condom distribution points in all the 10 provinces to strengthen community channels. So we are carrying out an extensive mapping of all distribution points in the 10 provinces. This is to ensure that we don't just have condoms arrive at a health facility or arrive at a local authority distribution point and they only remain there. But we want to know for each province, which are your key distribution points, and those key distribution points must be serviced. And when serviced, we must be able to report and ensure that we see progress and changes in terms of the numbers. As you could see, our overview, our numbers of HIV new infections are very high, and we need to reduce that to less than 12,000 by 2025. The other point of innovation is the engagement of community-based distributors. So we have community-based distributors being trained who will now be distributing condoms even within their community in terms of probably door-to-door as they carry out other activities. We've talked of integration. So as they carry out other activities, we want community-based distributors to also distribute condoms to the last mile, and also use the private sector and community engagement in achieving our last mile distribution. For the private sector, for example, we have the transport sector, we have those who deal with other commodities as they distribute their commodities, whether it's agriculture, whether it's moving people or moving other bulk commodities such as those who transport alcohol, to be able to say, using your cooperative advantage, this is an innovation that we have embarked on, that we want to ensure that they participate in the last mile distribution. Thank you. So lastly, we go to part 3, which looks at our challenges, our lessons. Of course, we have our current status. We're looking at what we are doing to address the status, but what are the challenges and lessons that we are picking up or we have picked up in this? Sorry, I was accidentally muted. So, challenges. Condom programming mainly funded. Our condom programming has been mainly funded from external resources. Even the public sector condoms are mainly supported by our partners who have put in quite a lot. And therefore, this for us is a challenge. And that if we are to attain sustainability, we need to address the challenge. So this is one of our major challenges, that our condom programming has mainly been funded from external resources. Then inconsistent data capturing and monitoring. Like I indicated, I think throughout, we are saying, why have we taken the TMA approach and why do we want to strengthen it? This is because we want to ensure that we have consistent data capturing and monitoring, because our challenge is inconsistent data capturing and monitoring. And therefore, that is why we also want to have a robust linked M&E system to help us. Then the other challenge is that ineffective coordination, demand creation, especially with priority populations. Over the years, we have mainly focused on general information, and we have had a situation where demand creation activities around condom programming, not just for priority populations, but has really dwindled down, that we haven't had so much activities promoting condoms. So this is a challenge in effective coordination of demand creation, especially with priority populations. In effective engagement of the private sector, we have more focused on the public sector. So this has been a challenge, and to the table, we don't have the private sector so much engaged. So this has been a challenge. And of course, they are profit making. So how do we bring them to the table? And that is why we see the cost recovery aspect as one of our elements. The last mile distribution for priority populations, we are saying that we have had an ineffective last mile distribution for priority populations. Limited availability and use of market data and consumer research. So this is another challenge that we have. Another challenge is that we experienced, I think, which I've mentioned, because our socially marketed condom programming has been supported by implementing partners. But when there's a change of implementing partner, one of the things we saw and learned is that at that point when there's a switch, there was a serious interruption of the socially marketed condoms on the Zambian market space. And therefore, for us, we picked this as a challenge that we need to work through with the partners. If there's a change of an implementing partner, we need to ensure that there's a smooth transition and it doesn't affect the market space. The other challenge, of course, is the non-availability of data collection mechanisms to capture private sector condom logistics and reporting. And I think from the beginning, why we are doing the TMA and why we are so strong on it is to ensure that we address this challenge, because we have not had a data collection mechanism for the private sector. And of course, you see our condom use is very low, whether it's among the adolescents, whether it's the general population, of course, apart from the sex workers who showed us a higher figure of 79. But the main challenge we have in condom programming overall is the attitudes and beliefs towards condom. And this is one aspect that we are hoping that through the TMA and the robust demand creation program, we will be able to address attitudes and beliefs towards the use of condoms. Next. Okay, so what are the key considerations for us to succeed, for us to have a successful TMA in our country as Zambia? One, we need to have an increased presence of the private sector, increased private sector engagement. That one we cannot underplay it, we need to. Number two, we need to ensure ensuring a sustainable health market. So we need to ensure that we speak to each other and see how local resources can come on board and ensure that we have a sustainable market, health market around commodities, around condoms and lubricants particularly. We also need to ensure that we have an understanding of the market conditions. So these are key considerations for us to succeed. And therefore the TMA is one of our greatest focus and strengths that we are using. We need to have an understanding of market conditions. And we also need to ensure the urban lower wealth quantiles where HIV is higher, having continuous access to quality and affordable brands. So ensure that there's quality distribution equity. There's also a balance in the different avenues. We have all the branded condoms in urban areas, but we also need to ensure that those that are going to the rural or lower wealth quantiles are also quality and affordable, and also they have access to them at all times. Next. Next. Okay. So the continuation of the key considerations, I think, go to the next slide.
Sorry, Ellen, there seems to be a delay between the slides moving. I'm on the second key consideration for success now. It should be showing shortly.
Thank you, Kerry. So the other consideration is, of course, to develop a clear market segmentation strategy for condom social marketing brands, and also the private sector. So we need to have a clear market segmentation strategy. The other consideration is to have timelines with the partners that we are working with, to have, in terms of, if you notice our elements, we have the recovery, cost recovery plan, but we need to have realistic timelines and to engage with the necessary support coming from all angles. Incorporate TMA metrics into condom social marketing portfolios, e.g. market size, access, equity, and sustainability. I think we need to ensure that the metrics have incorporated the TMA metrics, take into consideration the condom social marketing portfolios. And of course, encourage increased commercial sector participation in growing the condom markets. Ensure that we move from just having the free condoms to be more, but we also encourage that the commercial sector participates fully in condom programming, addressing HIV prevention, addressing STIs, addressing early and unintended pregnancies, especially teenage pregnancies. So these are the key considerations for us to succeed, or for our success to be visible, and for us to attain our success as envisioned. Next. Okay. Key lessons is that we have learned that we need to leverage all sectors, and it is very cardinal to an effective condom programming. It has been difficult. I think I've seen a question pop up. It has been difficult in the past. Probably our efforts were not so much concentrated together, and our focus was more on the public sector other than incorporating the other arms. But from the lessons and our experience at this stage where we are, and looking at our status in terms of new infections, even STIs or teenage pregnancies, we know that it is important that we leverage from each other, we leverage from the sectors. And that is why National AIDS Council, working with all the partners, the Ministry of Health and all other partners who are in this space, we are saying we need to ensure that we leverage all sectors. And it is very important for us to succeed. Of course, the other lesson is that sustainability of condom programming needs to be our priority. We have relied on resources from outside, from external support. But what we want now is to ensure that we work out through the TMA a sustainability roadmap, which can ensure that even if our funding from our partners reduced, the condom program will not be affected, because we will have adequate condoms on the market, we will have support through the private sector, we will also have support through the socially marketed programs. So this is a very, very important that we also saw that when we had a switch in implementing partners on the socially marketed ones, there was a serious loss of the condoms on the market, and it affected a lot of programs in terms of distribution and access to the socially marketed condoms. And they were a major partner. Although we have now another partner on board, but we experienced that gap when we were changing. So sustainability is very important. Equity in access cannot be overemphasized. We need to ensure that at all levels, whether it's in the urban or in the rural or the different subpopulations, priority populations, they have access to condoms. Effective use of limited resources, and I think this is why we are saying we need to work together. We need to be on the table together. We need to talk to each other, because we need to ensure that the limited resources that we have, we use them prudently, we use them to make a difference, we use them to target strategically where we need to target and ensure that we have gains around those targets. Effective participation of stakeholders for the last mile distribution, especially the private and community. So we need to ensure that the private are on board. So leaving them behind has not been helpful for us. We have been more focused on the public, just the public space. So we are saying our lesson we have learned is that we need to ensure that if we are to achieve the last mile distribution, we need the public, we need the community, and we need the private sector. We should not just focus on the health facility, but ensure that the community is saturated with condom distribution and they understand, they have information, and they're able to deliver. Of course, functional TMA dashboards. I should mention here, I think through the SSLN, we saw a wonderful dashboard that Nigeria presented on how they are functioning so effectively using the TMA. So we are saying that we saw from that, and we have learned a lesson from that, and which we are applying in our own to ensure that we have a functional dashboard for monitoring and evaluation of the dynamics of condom programming. I definitely know that the next time we present, we will show you a dashboard of what we are doing, like our colleagues did. We learned something from that, and we say that was a great innovation, and we have learned something from that. Next. Thank you. So I will end here. That was my last slide. I will now hand over for open discussion, and I'll hand over to my colleague who will take us through this next part. Thank you very much for this opportunity to present. Dr. Bupe.
Thank you, Madam Ellen. Thank you for the presentation on behalf of Zambia. We can open up now for some questions, and I've seen some comments on the chat. Let me just have a look and see if there's anything we can address prior to handing over to Mr. Kasonde. Thank you, Ellen, for the wonderful presentation. Can you please share with us why it has been challenging to coordinate the efforts of social marketing and commercial sectors with the public sector? What resources do you need to address those challenges, as well as other considerations for success have you laid out? Would you like to address that, Madam Ellen?
Okay, I think partly I touched on the first part of the question. Basically, I think our private sector has not been so much on the table when it comes to prevention issues, and they have been sort of left behind. That's what I would say. So what has been the challenge is that we left them behind. We more focused on public interventions, those that are supported by government and pushing the agenda for government. And we have learned that lesson. For us, it's a lesson learned that when we leave them behind, we may not be able to, we have not been able to move so much. And our dynamics also have been that the private sector coordination and has also been affected by our approaches, like because we have been more focusing on the approaches of targeting the health facilities and not putting condoms, and also our systems in terms of our belief systems. We have struggled a lot with condom programming because of faith, because of culture, tradition. Zambia has really, even adverts at one point had to be put down where we couldn't advertise. Immediately you do something, it's considered as you're promoting promiscuity. So we have gone through a number of challenges in addressing issues of condom programming as a country. So I think all that put together has contributed to us having difficulties in coordination and bringing the market players on board and leaving especially the private sector behind. The socially marketed programming aspect, we have at least been working very closely with them, especially that they are supported by partners. So we have to some extent worked with them, though of course we need to strengthen that collaboration. What resources do we need? At this stage is that we just need to, the immediate one is what we are working on, the strategy, the guidelines for TMA. We have been working on that so that we can have a proper regulatory and policy environment to ensure that we work together. So the resources that we need, of course, is to ensure we have trained distributors, we have our private sector on board and they also understand, so information, and also how do we agree with them, have MOUs on how they get on board, on how they contribute and what is in it for them. So it's information, of course, the financial resources, the human resources as well. We need that, and the systems in place. I don't know if I've answered, but my colleagues also can come in and answer some of those questions. Thank you.
Thank you, Ellen, and I hope that answer suffices to Chris Jones. There's one more comment that says, okay, from Thomas saying, I'm curious about why there is no data collection mechanism to capture private sector condom logistics and reporting. And I think this is, I don't know if you add to that, but you alluded to it, of how they've been left out of our response. And it's only now that we'll start to extend our data collecting mechanisms to them so that we can start to collect data. I don't know if you have any more to add to that.
I think that is adequate, because we have just left them behind. They've not been part of the whole engagement. We've engaged the private sector in other spaces, but in terms of condom programming, we have not fully engaged them. In other spaces we have, but I would say even our systems have been more focused on the public procurement of our commodities. And that is what we report on, and that's what we have been bringing to the table. But my colleague Maxwell can also mention something to that effect. Dr. Bupe?
Yes, I was hoping, I thought Mr. Maxwell was going to answer, but I think I'm okay on that one. Nothing else to add for me.
Okay.
Okay, with that said, I think we can move on to the next part. We can move to the discussions. Mr. Maxwell, would you like to take us through this part? Is Mr. Maxwell available?
Yeah. Good afternoon. Good afternoon. Are you able to hear me?
Good afternoon. You're audible.
Okay, thank you. So I guess this is an open discussion segment. And to start with, we can hear from the team what impressed you about Zambia approach, and of course, what else could have been of concern. Maybe we can start with that, if there's any feedback on that. So is there anyone? So I can't see any hands. Okay, Madonna, you can go ahead, Emmanuel.
Thank you. Well, on Zambia, I really liked your presentation. This is actually my first Link and Learn session. I just joined Genesis, I'm in West Africa. So I'm quite impressed with two things. One, the fact that you were able to decentralize supplies. You went as far as having a regional hubs. That is a very good M&E strategy. Though I would have, I wasn't something maybe I missed it, but I was looking forward to hear what it was before compared to what it was after you decentralized to having regional hubs. I didn't see that in the presentation, but I really love the fact that you had regional hubs. I mean, when things are, initiatives like this are done at the grassroots level, it encourages ownership among the people and some sort of sustainability. So I love that part. Then another thing I liked again was the fact that you have involved drivers and other people who do something similar in dissemination. You worked on what was existing in your structure of your location, and I think that is quite applaudable. Though the only thing missing now would be data to track all this, which I'm sure you will be working on. But this was a very wonderful presentation. I enjoyed every bit of it. Thank you.
Okay, thank you, Emmanuel. I don't know if there's any other, so that we move to the next. We'll give comments to what has been asked.
Okay, so maybe I can add to what she has just alluded to, what has impressed her. But indeed, maybe we didn't show what it was. What it was like, I think, as I was presenting, was that if you are living 1,000 kilometers from Lusaka, which is our capital city, you have to come all the way to apply for condoms and get condoms and deliver to the district. So what was happening is that was a huge challenge because transportation and all that. And then we also found when the central level is distributing commodities, you know, all of us that condoms are bulky, and therefore they would prioritize medicines first, go into the track. And if there's space, that's when they will put condoms. And therefore, what was happening is that many times all the districts were stocked out of condoms. All the provinces were stocked out of condoms. And the truck would move from here 1,000+ kilometers, deliver medicines, but there will be no condoms, or there'll be a small kit for family planning. That's all. So that was a scenario. And now at least you move probably the 500 or 400 to the point where the hub is. So that has reduced the distance. Transportation may still be a challenge, but in terms of distance and cost of doing business at that level has significantly changed. Thank you.
Mr. Maxwell?
Oh, thank you. Thank you for that, I think, response. And I think that was the situation. All the requests were sent to the central level, which is an average of 800 or 600 kilometers, and then be transported to these different regions. So now I think there's that collapse of distance. So maybe we can go to the next. Share your country experience with TMA. How does it differ from Zambia's approach? I don't know, is ready to go? Sharing your country's experience with regard to TMA. Is there somebody who is ready to share?
Yes. No.
Hello?
From Malawi.
From Malawi?
Yeah.
Okay, you can go ahead. Just try to be more audible.
In our country, I think the problem is not from availability of condoms in the facility, but now from the facility to the end user, who is maybe in a hard-to-reach community, or yeah, but from the facility, find that there are condoms. But where at the place where the condom is needed more, where we have a problem. So we are trying to do like use of CPTS, so that
James, we're struggling to hear you a little bit. Is there a different speaker you might have? James, we're struggling to hear you. Do you by any chance have another speaker or can speak a little loudly?
Device is ready to pair.
Hello?
Okay,
Can you hear me now?
Yeah, that's better.
Okay. Yeah, I'm saying we have issues with the availability of condoms to the end user, not facility level. Our systems are able to distribute condoms from the central medical stores to the health facilities, even the rural health facilities. But now to have a system whereby the condom is now, we are now strengthening as of now by engaging community-based distributing agents, the youth, and other structures in the community. Because if you need a condom in the facility, in the community, there's no ways you can travel all the way to the community, to the health facility to get the condom. It has to be found right in the community, and the approach should be peer-led, whereby a youth can get a condom from the youth, from a fellow youth, or an adult gets a condom from a fellow adult through the use of the system that we are developing. Thank you.
Thank you for that. Thomas, you can also share your country experience.
Yeah, I just want to add to what observation about what James said and what was presented as a challenge during the slides. It seems to me that both in Zambia and in Malawi, the last mile distribution is, they have similar experiences that it's not working very well. So my own observation is that could it just be the problem? Could the problem just be related to distribution? Do we know if the demand is there at the local level, at the community level? Because I also heard during the position that there are issues of cultural beliefs and attitudes that are preventing people from using condoms. And I know social marketing sometimes might not focus on addressing those cultural beliefs and those attitudes. So I'm just throwing this up for discussion. Is it just a question of distribution at the last mile, or do we also consider issues of demand of condoms at the communities? Thank you.
Okay, Job, you can go ahead.
Thank you very much. I'll just share the experience from Kenya, and apologies for joining late. Kenya has a similar experience. We have decentralized our distribution so that condoms are now found in the regional stores, the KEMSAs, which supply the condoms, so they're available in the regional stores. The huge challenge in Kenya, just like our colleagues are sharing, is distribution beyond the health facility in the community where the end user is found. That's where we still have challenges. And in terms of TMA, our condom market, when you look in the country, is heavily public sector. Over 84% is public sector, free for distribution. The socially marketed commanding almost 14%, with less than 2% of the commercial brands in the country. So what we are grappling with in the country, how do we slowly by slowly increase the contribution of the private sector so that even as the country becomes middle income, the people who can buy are able to buy the condoms, then the priority populations, the vulnerable ones, the free condoms are available to them. So it's a similar situation which you are struggling with, but we are happy with this learning experience we are having. Thank you, and over to you.
Yeah, thank you for those comments. And maybe before others could have more comments, in terms of demand versus distribution, one of the observations is that when there are public events or ceremonies, let's say traditional ceremonies and other school events, if condoms are taken there, whatever the number, 500 pieces or 1 million, within a day or two, all the condoms will disappear. Of course, one will ask you whether they are using them, but that's another question to answer. So the observation is that the demand could be there, but we need to unlock the condoms to reach the community channels. And I think we can learn from the public sector strategies of how, let's say, Coca-Cola is distributed and other foodstuffs or beverages. So maybe those are some of the things that we can start looking at to learn lessons or cooperate with such, so that we can have more condoms at community levels. There's another hand. Is it Inzidio? Not sure if I'm pronouncing it properly. You can go ahead.
Eu vou falar em português, se calhar fazer a tradução para inglês, né?
Yeah, you can just project yourself.
Ok. Eu chamo Isidio Nhantumbo, portanto, sou dos champions de Moçambique. Desde já agradecer aos colegas da Zâmbia pela apresentação feita, que é uma apresentação que reflete bocado daquilo que também está a acontecer em Moçambique. Não estamos ao nível de implementação desta abordagem total do mercado, ao nível que a Zâmbia está, mas já temos com um estudo, a análise situacional feita. E muitos dos problemas que apareceram aqui nesta apresentação acontecem connosco cá. O sistema, em termos de papel, está feito, mas a sua implementação é que é problemática, portanto. E o grande problema é este que está-se a falar aqui, que é o ter o preservativo no last mile, não é? Nós temos problemas sérios de transporte, conseguimos transportar o preservativo do nível central até as províncias, mas quando nós queremos depois ir aos níveis subprovinciais, começamos a ter um bocado de dificuldade, que faz com que o preservativo, na verdade, não chegue a quem deveria chegar. Quais são as alternativas? O que se fez foi, na ótica da subvenção do Fundo Global agora, há um contrato que está a ser fechado, portanto, com o projeto Last Mile, para nos apoiar em ideias e ações concretas, por formas a que nós possamos desbloquear um bocado esta situação de termos o preservativo com dificuldades de descer até os níveis mais baixos. Aqui no país temos sim o preservativo nas unidades sanitárias, mas estas unidades sanitárias encontram-se distantes das comunidades. Então, a estratégia é ter um mecanismo de ter o preservativo nas comunidades, e para isso nós contamos com aquelas organizações comunitárias de base. Então, vamos ver sim com este projeto Last Mile, se nós, na verdade, conseguimos ter o preservativo para quem precisa, porque as ações de criação de demanda estão a acontecer, mas as pessoas se mudam o seu comportamento e depois não têm acesso ao preservativo, portanto, aparecem estes números todos que nós temos aqui. Muito obrigado.
Thank you. I'm not sure how can paraphrase for others just to benefit. Kerry, are you able to?
Sorry, Maxwell, are you?
Yeah, I was saying, are you able to just briefly run through what you were saying so that others also can respond?
Sure, Maxwell. I hope many of the colleagues might have been able to listen to the live interpretation on the English channel. Yeah, colleagues should have been able to hear what he was saying. But I think in essence, what Isidio was saying is that they are not quite as far along with the TMA approach in Mozambique as the Zambia presentation has shown. They were suggesting that the greatest challenge that they face is the last mile distribution and getting condoms into communities. He mentioned that they have an agreement with Project Last Mile that they hope will support them in overcoming this challenge. He mentioned that there seems to be greater demand growing in communities, but that if condoms can't be accessible to people in communities, then that doesn't actually matter or have any material effect on condom use in the country. I hope I've done justice in synthesizing that, Maxwell, but I think that was the essence of what he was mentioning.
Yeah, thank you. So unless there's someone who wants to share some more country experiences, we can go to the last part. Do you have anyone want to share on the country experience? I think we heard from Malawi, Kenya, Mozambique. If not, I think we've picked some of the similarities in terms of challenges with the last mile. So we have two questions there. How do we practically apply the cross-country learning that we are doing? And then which conversations can now take place across or within countries? What do we think we should be the focus in terms of conversations? So anyone can come through. Do we have anyone who want to contribute?
Maxwell, it's Kerry.
Okay, then go ahead.
I'm quite interested, you know, in the fact that there seems to be such a shared kind of voice and experience in terms of total market approach and last mile distribution. Many of the countries on this call are also countries within the Condom Strategic Initiative. I think 3 of the 4 countries certainly are. And so I was thinking it might be worth considering another forum, you know, perhaps to brainstorm or problem solve or, you know, share how countries are using their own strategies to overcome this. So perhaps if countries are interested, at least 1 or 2 people, we'd be happy to, you know, continue this conversation as the Zambia TMA strategy gets finalized, you know, as each of the countries kind of grapple with and try to overcome some of these common issues that'll be in face. So that's just from the South-South Learning Network side.
Okay, I think that's very important. In terms of moving this agenda forward, that will be very, very important. Do we have any other contributions in terms of the conversations that we need to put on the table?
Yes, I've raised my hand.
Okay, you can go ahead.
Yeah, I wanted to, the issue of engaging the private sector, like the transporters of beverages and other food items, to help in the distribution of condoms. I started to learn what are the plans. Are you going to to engage them and then on a contract basis, so that be paying them for the distribution that they have done, or is it part of their social responsibility? Just wanted to learn the approach.
Yeah, so unless we have a country that has already engaged such institutions or companies, we can have feedback, but it's just worthy to learn lessons from such efficient distribution from such companies. So I think it's just an idea. We don't know if we have any experiences from other countries.
All right, thanks.
Okay, Ezedio?
But maybe, Max, to add, the idea is not to contract them like a business, but to use their comparative advantage. For example, as they are distributing cement, they are taking all these commodities to the last point in a country, in our case, to our last districts, the last point districts. How do they, because they have the transport, how do they go there? How do they manage to go there? So can they be able, because one of the challenges I think across all the countries that we have seen is the last mile distribution to get the commodity to that person who needs to use the condom, that young person, that a person living with HIV. So as you said, the health facilities may be far. So for us, we have been working on this one in terms of engaging to see how can we use the comparative advantage. They are going to the last point in this country where we may not be able to take the condom, but can they be able to carry a box, 2 or 3, in addition to what they are taking, and leave it where they are going. So that is the idea, not to contract them on commercial basis, but to use their comparative advantage as they carry out. So you'd say that there's corporate social responsibility as well. Thank you.
Great. So those are innovations that we need to think through and see how best it can work. So I have those, I think, 2 ideas that needs to be looked at within countries. And if we don't have further discussion on this, we can hand over to the next segment. Thank you very much for your attention.
Thank you, Mr. Maxwell Kasonde. We'll immediately move on to the next part of our session, which is looking at next steps. Mr. Daliso Mumba, are you able to lead us through this?
Good afternoon, everybody. I see that there's a hand. I see that there's a hand up. I don't know if that question has been addressed from Izidia. I don't know if I pronounced your name right. Okay. I guess maybe it's a forgotten hand. My task is very... Okay. So my task is very simple. I think for us, it's just to share the next steps from participating countries to share their own takeaways. Maybe we can go, who's willing to go first to just share with us what their takeaway is from Zambia's presentation. I know Ellen but a lot of things talking about the total market approach and our plans for the future. So I think us, we would just like to know what are the key things that we share that you think you can adopt in your country as you plan for next year or as you plan for end of year. Thank you. So maybe we can start country by country quickly, very quickly. We can share some next steps or some key takeaways from our presentation. Thank you. Anybody willing to go first? Felix, Gloria, James, Anybody willing to share with us some key takeaways from our presentation?
I think in our case, Malawi, we are at the point of finalizing our last mile distribution strategy, and now we have learned from Zambia on the issue of engaging the private distributors, something that we can learn and see if we can incorporate in our strategy. So this is an innovative idea that we have taken away from this meeting. Thank you.
Thank you very much for that, James. Anybody else willing to share the key takeaways from today's presentation?
Yeah, it's just maybe the partnership between the three, you know, just to see how it works. And maybe you've heard from Joab, also from Kenya. I think the biggest problem we have is the whole supply chain management. Who does what, where the condoms are going, and how then do we bring the key players into the space and really working together, because it's one thing for distribution, but it's another thing for also use. And for Kenya, we have like decentralized government. So we have like 47 counties, and each one has their own needs differently. And so getting into that space and actually understanding what are the needs where we have done before, because that's what we have done before, like looking at how many condoms are needed by each county, what is the partnership that we need in that county. But the coordination part of it, I think that's still one of the biggest challenge. And looking at what Zambia is doing and trying to do, I think this could be a good lesson learned for us to see how then we can actually go to the 47 counties and looking for those relationships where we can actually do a better coordination, and so that we know who needs what. Yeah, thank you.
Thank you very much for that detailed takeaway. I think it's good to know that at least Kenya is making some significant strides on trying to address some of the challenges that they're making at the moment. And I think earlier in the presentations, there was comment of how country-to-country learning is key for this. So I think we're always available to assist and share our experiences with colleagues who would like to learn and adopt some of the strategies that we have. Harriet, I see your hand is up.
Yeah, sorry. Thank you for that opportunity. I am speaking from Zimbabwe, Harare. Key takeaways. I think just listening from the to the presentation, one begins wondering about the whole challenge about condom programming being really supported so much by donors. So the issue of sustainability, the issue about countries taking up this responsibility more and more, I think comes to mind, and I think discussions around this moving forward would be very important. Just looking at the fact that condoms are a very strategic and a key element when we are talking about prevention. And therefore, even as we discuss the whole issue about sustainability in the HIV response, I think it's important to look at sustaining the efforts by donors, but at the same time ensuring that more and more of the condom programming is actually taken up by governments. Thank you.
Thank you very much for that, Harriet. Thomas, I see your hand is up. Please proceed.
Yeah, one key takeaway for me is the issue of having a system in place. I mean, whatever LMIS system we have, to integrate it with the private sector from the beginning instead of waiting. It looks like it's better to start early to understand what the private sector is doing and have it captured in our systems and reported accordingly, than to wait later, because once we wait later, then we might not be able to have the private sector totally on board, because the whole idea behind the total this strategy is to make sure we succeed at every level, private sector, public sector, and at the community level. So that's a key takeaway for me.
Thank you very much, Thomas. So maybe we can take one more. Anybody willing to share with us their key takeaway from this presentation? Maybe we can get one of our colleagues from the Portuguese-speaking countries to share with us some of the key takeaways.
Temos alguém mais aqui que não seja Moçambique, que já falamos, mas pronto, podemos também dar a nossa mensagem. É uma experiência que vale a pena reter, sim senhora, e acho que quando voltarmos para casa, sim, poderemos ver o que é que a Zâmbia está a fazer e como está a fazer, e como é que nós iremos adequar aquilo que é a nossa realidade moçambicana. O país também é grande, nós temos distância aqui de 3.000 quilómetros para a capital, e é preciso ver essas especificidades, como é que a gente consegue. Além das distâncias, temos etnias diferentes, portanto, é um mosaico também cultural que contribui também com as suas barreiras para o insucesso, talvez, deste processo todo. Mas pronto, vamos olhar para esta experiência boa e tentar adequar naquilo que é a nossa realidade moçambicana. Muito obrigado.
Okay, thank you very much for sharing that. So I think, thank you all for sharing those takeaways from our presentation. I think, like I did mention, my task was very simple. So I'll hand back to my colleague, Ellen, to give us some closing remarks as we conclude our presentation. Thank you very much.
Thank you, Daliso. I think I will ask Dr. Bupe to do the concluding remarks. And thank you, everybody, for the input and the points you have raised. Thank you. Dr. Bupe.
Thank you, Ellen, and thank you, Daliso, for the sessions, and especially Madam Ellen for the presentation. And thank you all colleagues for joining us and hearing our experiences and for sharing your experiences as well. It has been very informative, and it's also quite enlightening to see what's going on or to know what's going on in other countries. So thank you so much for your participation and for joining us this afternoon. I'll hand over to Mohammed to close the meeting for us. Thank you so much.
Thank you, colleagues. This has been a really interesting session on the total market approach. And I just wanted to send a special thank you to the Zambia team for hosting the session, as well as all the countries who have participated and contributed towards this topic. As we close, can I please invite you all to take part in the poll that should be displayed in front of you now, and remind you all that the presentation will be shared with all present in the next week. If you have any further questions or want to engage the Zambia team further, please reach out and we can put that together. I hope that you have found this enjoyable and also informative. And if you do find any other areas you'd like to share, please do reach out. Thank you all.